Good afternoon, everyone. Welcome to the BC Refugee Hub's webinar entitled Primary and Mental Health Care Supports for Refugee Claimants. My name is Farah Kotadia, Program Director at AMSA, and I will be guiding us through today's event. We are all here at the ISS of BC Welcome Centre in Vancouver. The BC Refugee Hub would like to thank AMSA for hosting this webinar and providing technical support for this online session. The BC Refugee Hub is funded by the Province of British Columbia and administered by the Immigrant Services Society of BC, or ISS of BC. The BC Refugee Hub would like to gratefully acknowledge the financial support of the Province of British Columbia through the Ministry of Jobs, Trade and Technology. This webinar topic has been informed by a feedback survey conducted with the settlement and integration sector by the BC Refugee Hub. Many survey respondents expressed a need for training with resources and information on primary and mental health care for refugee claimants and how to navigate supports this client group faces during their settlement journey and their claim process here in Canada. Many also expressed the need for regular trainings like this for staff as ongoing professional development. This webinar is suitable for those working in frontline positions, coordinators and managers at settlement service provider agencies, as well as community partners and stakeholders who work with and support refugees and refugee claimants. The webinar today will cover the following from our speakers. Bahar Taheri from the BC Refugee Hub will give us an update on recent resources posted on the Hub and upcoming training events. Then Mariana Martinez Vieira, Clinical Supervisor from the Vancouver Association for the Survivors of Torture, or VAST, will present on trauma-informed practice and how frontline staff from settlement and community organizations can best support vulnerable refugee claimants. We will then have Byron Figueroa, Health Promotion Case Manager, Settlement Orientation Services, or SOS, who will provide us with an introduction to primary health care for refugee claimants and review IFHP and MSP requirements and eligibility. Our final speaker will be Dr. Mei Ling Wiedmeyer, Clinical Instructor, UBC Department of Family Practice, Family Physician Umbrella Multicultural Health Co-op, who will review common challenges and access to healthcare for refugee claimants, and she will also begin our panel discussion on how to address challenges and improve access. First up, we have Bahar Taheri from the BC Refugee Hub providing a short update on events.
Hi everyone, thank you for joining us for our last of our webinar series. I just wanted to bring your attention to a few resources that have been released recently. The first one is the BC Refugee Hub Refugee Claimant Bulletin, fourth quarter statistics and 2018 roll-up. I know we're in March already, but a lot of people are writing CFPs, so this is a really good resource for some stats. And we're going to be releasing the new one in April 2019 for the first quarter of 2019. And then the next one is the BC Settlement and Integration Service Stream A and B services for refugee claimants. So this is an inventory of organizations that have been funded through the BC SIS program, the provincially funded BC SIS program. And this is for Stream A and B. Refugee claimants are eligible to access services from organizations that have been funded through Stream A and B. So this document has a list of organizations in Fraser Valley, Metro Vancouver, and Vancouver Island. And it also has a really great inventory of free or low-cost English classes that refugee claimants can access in the different regions. Next up, we just posted webinar materials, video, and PowerPoint deck from our February 11th webinar titled How to Support Refugees and Refugee Claimants Facing Domestic Violence. You can find this under training on the Hub, And we also just had a webinar on employment supports for refugee claimants, and the video and PowerPoint deck for that will be shared next week. So I'll send out an email to everyone that registered for that one, and I'll also post it on the hub. And next week we have an in-person event on March 12th, Tuesday, and that's LGBTQ Refugees and Refugee Claimant Forum. Registration is now full as of this morning, so we have 80 participants attending, which is amazing. And you can, once that training has completed, I'll put the PowerPoint decks for that on the hub as well, so anyone that couldn't attend can still access the trainings. So everything can be found under training, or if you go under what's new, that's updated regularly as well with events, workshops that refugees and refugee claimants can access, and anything new that goes up on the hub is under that section. If you have any questions about any of these resources or any suggestions for topics on upcoming trainings, you can email me directly at refugeehub@issbc.org. And the Refugee Hub is at bcrefugeehub.ca. Thank you. That's all from me.
Great, thank you, Bahar. So I would now like to introduce Mariana Martinez Vieira, Clinical Supervisor from VAST, who will present on mental health care for refugee claimants. Welcome, Mariana.
It's good to be here. Thanks, everyone. And I would like first to start by acknowledging the land from where we broadcast, where we gather today, and the land that we're on here at the ISS of BC Welcome Center, the unceded territories of the Coast Salish people. Here we are today, and it's good to be here. I'll jump right into it. For the sake of time, there'll be lots of time for questions. So if you see me seemingly rushing, know that we're going to go back to things as a team as we move forward. So let's take a moment to land, and maybe wherever you are, guys, take a deep breath out or stretch, yeah, and shake it off. Anything that you need to do that helps you be more present, more here. We have a chunk of time together to share expertise, experience, knowledge, and for you to reflect on yours. Hopefully, we can instill that curiosity. I've been with the Vancouver Association for Survivors of Torture, working with refugees at large, and very specifically with refugee claimants, the ones that we're going to focus on today largely, for the last 16 years. And I also did that work in Latin America prior to coming to Canada. So what I'm going to bring here today is my challenge to summarize the practice and hopefully bring some tips for you to best serve refugee claimants. And so I'm going to talk about vulnerability and how to assess for vulnerability. And this is not a trauma-informed practice session. I know you have had some very good ones recently, but we'll definitely tap on trauma and what it is. And let us move forward to get us started even more. Let us have a quick survey. That's always important. At least I would appreciate it to get a sense of who we are today. How many of you are settlement workers or workers more focused on employment or housing?
It says about 46% are saying that they are settlement workers, and 54% are saying they are not.
Okay.
Yeah.
Kind of halfway.
Yeah.
Okay. We'll get it going. Interesting.
Okay. And then the next question you've asked is, are you an employment or housing worker? So we've had to break these questions down in terms of the technology. So
of course.
Yes. So the next question. 7% are saying yes, and 93% are saying no.
Interesting, right?
Yeah. Are you a primary health worker? Okay, so 91% no, are not primary healthcare workers. 9% are.
Okay, great.
Yeah.
And lastly, a counselor, someone working.
So 9% yes, and 91% no. So I guess that other box is where most people fit in.
And that helps us, right? And to guide, to tailor the conversation, because this is about both a conversation and to best understand and acknowledge the knowledge and the experience on the floor. Okay, let's move forward. Okay, in case some of you do not know VAS, I had to go over this. The Vancouver Association for Survivors of Torture, a non-profit grassroots organization that got established in 1983. We can move to the next one, our mandate to best guide us in 1986 to support the human rights and the mental health of all refugees arriving in BC with psychological trauma as a result of torture and persecution on the basis of political opinion, race, religion, sexual orientation, gender identity, and expression. So we work with all refugees in Canada, and very specifically, I'm going to focus on refugee claimants today. And what we do is we provide individual counseling for all ages. We provide neurobiology-based treatment for trauma, the type of trauma that really work, the type of treatment that really work to advance recovery for trauma. And we also approach recovery by doing groups, and there are many good reasons for doing that. The community building piece and the trauma-informed groups that we offer are all about that. And I cannot go at length about this because I could talk for days, and I'm trying to not get carried away. We do community and peer support, training and education. These wonderful opportunities to share are part of that. And one that I underlined purposefully was psycholegal documentation. We, over the years, have been more and more approach to provide clinical assessment reports to help refugee lawyers, IRB members, all the different players, right, that make decisions around refugee claimants' lives, better understand the experience of this individual that may struggle to give testimony, that may struggle to access services. So we take lots of pride at VAST to say that we are specialized in providing treatment, assessment treatment, and providing appropriate and relevant psycholegal documentation. And that's a big piece of advocacy when it comes to the work with refugee claimants. And advocacy and activism was below, right? But that's top on our list. And then we are also recipients of funding through the province of British Columbia, again, acknowledgement to our funders, right? To have the provincial refugee mental health line that we are kind of improving even more these days so they can really be used to the most. And I'm aware that I used the word a number of times, and we're not gonna delve on this, but maybe it's always important to take a moment to reflect on the concepts, right? The words that we use. And maybe I should have said here, for this purpose of today's conversation, who is a refugee claimant? Let's refine that. Who is a refugee claimant? So any thoughts that you guys on the other side have? We are not requesting definitions, but thoughts, right?
For sure. Feel free to, those of you who are participating, feel free to write your answer in the question box there. You know, who do you think is a refugee claimant? Be good to get some interaction.
Yeah. What is it that is so specific, so unique of about a refugee claimant's experience?
Yes.
As opposed to other refugees, for example.
Right.
And as opposed to immigrants, for sure. What is it, that uniqueness of a refugee claimant's experience?
So again, feel free to use the question box
we can
and offer your thoughts.
Shall we get going as people? This is just to make us all ponder. Okay. Who are these people that we're working with?
Yes. So one person has
what they're going through. Yeah.
One person has said a person whose life is in danger.
Yeah.
That is a refugee claimant.
Yeah.
It's very true.
Yeah. We can get going. Yeah. And what best than to, reach out to people with lived experience. And here we have our lovely, and so ours is, I'm kind of claiming ownership of Sarah, who is my dear colleague at VAST, and someone with lived experience. And when approached by the discourse during a research project and asked to share what people, not only at refugee serving agencies, but people at large should know about refugee claimant, right? or you like other people to know about a refugee, being a refugee is a circumstance, not a lifestyle. And oftentimes, Sarah adds, and Sarah, if you're there on the other side, yeah, I will borrow your words. It's not a choice. It's a circumstance or a set of circumstances. And definitely, as our friend on the other side pointed out, risk and threat and life at risk is a very distinctive one. Okay, let's move ahead. And many of us sharing this time today, maybe working with all refugees in Canada, with different ones in different capacities, but the conversation today is about this very highly marginalized group of refugees to be, actually, right? They usually call asylum seekers overseas. So we in Canada have this term, refugee claimants. There's something important to keep in mind from a mental health perspective, but in general, from a humanitarian perspective, and that I would say applies to the work that any of us do, is to be very cognizant of the continuum when we talk about trauma and challenges. And there has been loss that happened already way before we meet these individuals in the pre-migration phase and the migration phase, the journey to Canada, state violence, displacement, life threats. We're not going to name them all. We probably are all going through many, many associations of the stories of people that we have witnessed. But what about the resettlement challenges and the potential trauma in the resettlement phase, right? If the system, if the services are not sufficiently trauma-informed. And this phase, the resettlement phase, is the one that we are part of. And it is the phase in which we can effect change. So I'm going to focus lots on that. Something to keep in mind, some guiding principles for us at VAST, and I bet that many people will share them. So important to, especially when talking about mental health, to keep in mind that what we observe, what we witness in our clients, and even the word client, right? But I won't get started there. What we observe, what we witness, we could think about those as normal responses to abnormal situations, which could be a tentative definition of PTSD, I would say. We need to value, to acknowledge at all times when we're working with clients in order to be trauma-informed, the persistent resources, the resiliency that these individuals bring, and to build from that. And that kind of taps on the concept of post-traumatic growth. And some people may have heard about the work of Tedeschi, Joseph, and many others. This reframing of trauma and recovery and making meaning in terms of post-traumatic growth. So I wanted to mention this to set a tone, right, of what type of mental health supports really promote healing and acknowledge the experience of refugee claimants and honor their human rights to good services. Yeah, there's more. So some quick quotes on trauma. I promise not to get carried away and kind of put my clinician's hat aside. It happens when all resources seem inadequate to cope with external threat. And trauma as a loss of connection to ourselves, to our bodies, to our families, to others, and to the world around us. That's part of the reason why we do groups as a pillar of recovery. Loss of connection, right? And by the way, these are top names in trauma recovery literature, right? And lastly, and to do it very quickly, trauma is a psychophysical experience, even when the traumatic events causes no direct bodily harm. It is not in your mind. It is not in the facts. It's not about the facts. It's physiological. The whole system is at rest. That's why I said at the beginning that at VAST we provide neurobiology-based treatment for trauma. Yeah, we talk, but we approach the recovery from a body-oriented, neuroscience-based framework. Otherwise, things don't move, and we constantly revisit, and that's not the point. So I promise not to get carried away, so let us move on. And here, in a nutshell, in a very, very nutshell, anything that overwhelms an individual's ability to cope. And very important when it comes to thinking about our practice with clients, delivering mental health services, but settlement services, housing services. Trauma is and has been a crossing of boundaries, a rupture of trust and safety that brings that disconnect. So our being intentional, collaborative, accommodating makes a huge difference, brings an opportunity to repair. And that's healing in itself. We don't need to be counselors to offer that. Okay, let's move away because I cover it somehow. And you'll get the PowerPoints, so don't worry. Yeah, PowerPoints, right? Let's move ahead. So what does this thing called trauma look like in our work, in the cubicles where we work, or rooms, or at the front desk and the reception? Things that we encounter that may stand in the way of our working with clients: difficulty concentrating, easily distracted, fogginess, that may cause us to start feeling foggy and sleepy or disengaged. Difficulties keeping or remembering appointments, as inconvenient as it is. We may have reactions, we're human. The sense that the body is there but the mind is not, the quality of presence that may be reflected in the gaze or the posture. And then the next ones are also interesting because it taps on our reaction. Someone being seemingly non-cooperative, disengaged, resistant, some people say. Someone with an attitude or a temper, highly emotional. The ones that receptionists of very frontline people say, oh, okay, this is your client. Your client is here. Okay. And someone seemingly manipulative, flippant, reactive. You are the lifesaver one day, but the next day or minutes after, you're one of the very many that has betrayed or disappointed this person. And this is not to say that there are no personalities. And at all times, this is all about post-traumatic response. We don't want to enter a pathologizing frame either, right? But these are things definitely that have to do with the rupture of trust and safety, with boundaries crossed, with folks that we need to work with while being cognizant of all this. And this happens not only in the counseling room. That's why all workers supporting refugee claimants need to be, and lawyers, refugee lawyers, and the IRB, everyone has to be aboard to how to interview, assist, book, do intake, when to ask a question, when not, how to provide roadmaps so people sense that collaboration. Those are very important things to keep in mind. And I know the PowerPoint doesn't serve my purpose of trying to keep it all in a nutshell. Let's move. So let's skip this. What I wanted to say with this, that one of the tools that we really highlight to best support refugee claimants is the Getting Through group, or any group that brings the trauma-informed lens with information delivery, information sharing, but also building resources for self-regulation, psychoeducation, allowing an ongoing assessment of refugee claimants, how they're doing in terms of concentration and presence, referring them to appropriate resources. That's what we do at the Getting Through It at VAST every Wednesday at 10 o'clock at this center. But we also have a version of the Getting Through It that we do at Options Seri on Fridays. So contact us for further info. But this is a very good intervention. And as early as possible, having refugee claimants accessing it, not prior to the hearing, as early as possible. It's a long continuum of challenges. And group work is great. And I know that many people out there must be nodding, same as in this room. Let us go ahead. So these are some testimonies that you'll get to read. when you get the slides. But I just go to one, sit in a circle, and a refugee claimant saying, look right, look left. There could be your friend. A sense of community witnessing. That is therapy at its most. I mean, we are creatures of attachment, right? So, okay, let's go. Some art modalities are absolutely suitable to work cross-culturally and to promote healing. Let's keep going. This is for the sake of fun. Yeah, we keep going. And I'm going to talk a tiny bit. Yeah, I have 5 minutes to introduce you to a tool that will help you if you want to incorporate it. The BAS vulnerability assessment tool. Let's go straight ahead. I include the definition of vulnerability because we might say that all our clients, all the refugee claimants clients that we work with are vulnerable, considering the struggles that they've been through. But when it comes to refugee claimants and going to a hearing with the Immigration Refugee Board, there are specific guidelines to define vulnerability. So we're not going to go into that, don't worry. But it's good for us workers in different capacities to know how to assess for vulnerability. And we do not need to have a clinician's hat to do a first screening. We're not diagnosing anything. We're screening to take action, to introduce early interventions. So I will introduce you to the tool. There's going to be time for questions that I'm going to share with my colleagues here, and the tool will be shared with you by the Refugee Hub and AMSA. Okay, so let us move. It is a 3-part tool. Part 1 is 10 questions refer to settlement, and maybe things that you have already been asking and things that you know about the client. But keep a constant update of those things. What resources the client has available? Who are the other players that can help me do this wraparound assistance of a refugee claimant client? The second part is a mental health screening tool. And the third one, but is the last but not least principle, is an exploration of resources available. What helps this refugee claimant function and cope? So the last couple of minutes I will focus on that. Let's go ahead with this slide. Anyone can administer. You see, almost all of us. But it's not to be self-administered. So you don't give the paper to the claimant. Mm-hmm. Yeah, it's better not. Yeah, go ahead. Yeah, let's have the other slide. The next slide. Yeah. So the question is to see. I'm not saying here that it's rocket science that we invented the wheel. This is a tool created by BAST, but just reminders. We need to know who the settlement worker is, the doctor. Is there one in place? And so mental health services available. The next one, please. So 10 questions to get the lay of the land with a refugee claimant. And in this particular case, the more affirmative answers we have, the less vulnerable we may say this claimant is, the more access to services this individual has had so far. But I may need to jump in and do some referrals and work and strengthen the resources. That's the part 1. The part 2, and maybe the one that I'm going to focus more on, not too much, don't worry, is, let us go to the next one. 10 questions that tap on the criteria for PTSD, although we are not diagnosing here. And we have very similar wording. Do you often? Do you often? And the more yeses, as a kid would say, the more affirmative answers, the higher the vulnerability. This is, by the way, the PROTECT questionnaire that was developed by the RCT, the International Rehabilitation Council for Torture Survivors, and we at BAST borrowed from it and adapted it for the BC context. I want to acknowledge that, right? So the PROTECT questionnaire adapted by BAST. So anyone out there listening could start implementing this, having it as a reference. I don't want to undermine any tools that you may have been using, but count on this one. And you can actually print a copy, and we have done it, and sign it and give it to the claimant that is going to report to the CBSA. You know what I mean? It's so important. And it can be a first step to decide that you need to refer this individual to a clinic, to a primary health provider, or to a mental health provider, and as soon as possible. It indicates priority. So those that score medium to high should be referred to a clinician promptly. This is a recommendation. The next one. And as I said, and last but not least, I many times start with this one. Exploring, this is a highlighting of, this is very important part. We have arranged on the sound effects, don't worry. This is to stand out what I'm saying. So let's not forget to remind our clients of the resources that they have. They made it here. We're not painting the picture rosy, but it's true. They're here. We are here, and it's always good to emphasize present moment, right? So what has helped you get through the most difficult moments? Oh, please, any other question that seems more appropriate. It doesn't have to be this one. Okay. Maybe right now, guys, you're coming up with other alternative questions and much better than this one, more suitable to who your client is and who you are. But there are resources that have got you here. What are those? Internal, external, spiritual, relational, somatic resources. So with this assessment for vulnerability, you can make decisions. You can take actions. You can refer. You can book a client. You can collaborate with another worker. You can decide that maybe you need to contact, depending on your role, you need to contact the refugee lawyer working with this client. Or the housing worker that works on the same building, etc., etc. So wrapping up here, really, how to refer to us, you have it here. We have services here at the Welcome Center in Vancouver, as we've been doing it for a couple of years now. In Surrey, at the new ISS Center, and with options close to Surrey Central, and soon to come Victoria. But we are not the only ones, and that's good. So the next one, the last one, other services. The other day, I know we heard Alexandra, from Mosaic say that they have partnered with Abbotsford Community Services in the Valley to do the mental health piece. Great. They are there. Diverse City in Surrey. Mosaic Ending the Violence program, another very suitable program. They're aware of the forced migration refugee claimant experience, which makes the work very specific. Mosaic I Belong program for LGBTQ refugees. I'm part of that program as well. The program includes individual counseling as part of the components. And last but not least, again, Battered Women Support Services. The framework that they utilize and they are understanding of the migrant experience makes them a very suitable referral option, right? For all of us that may need to find further resources to best serve refugee claimants. And let us remind ourselves, refugee claimants and empowering them and best supporting them is also time sensitive. Even when the claim is now reported to be 18 months plus, but the way things look like these days, people do not get a hearing aid right off as they used to. But when they do get it, it's happening soon. So the more we've done this, the better we've been at identifying vulnerable claimants, referring them to services and keeping them under our wing or in a network of service providers, the best prepared the claimants will be when all of a sudden they get the desired date, but they may start to freak out. Okay, and we with them. So, okay, so yeah, that's about it for now. I pass it on to my very dear colleagues here.
Thank you, Mariana. And you said earlier that you could go on for days. I think
Exactly.
It's a very rich topic with so many layers that you're right. There's so much to talk about and discuss and unpack. So
absolutely.
Thank you very much for that.
No, not at all. But it's very
yeah
exciting to be here and also share. Yeah.
We do have time for some questions, and we have lots of questions, but we'll take a few. How is mental health and trauma different for refugee claimants compared to others? What is specific to a refugee claimant situation that may impact their mental health?
Okay, I love that one. Okay, refugees, whether they are resettled or previous claimants or refugee claimants, we all have nervous systems. And from a neuroscience perspective, one might say, yeah, the amygdala, the thalamus, the hypothalamus, right? Those systems are in place. But there's something that has to do with the refugee claimant experience, which is something that I just mentioned toward the end in a way, the time-sensitive frame, the uncertainty. Refugee claimants are the way a refugee claim process looks like these days. They're expected and asked to resettle while they do not know whether they'll be able to stay. In this 18 to 2 years timeline that the refugee claim takes, they have to start working, they have to start doing stuff, finding housing in these regions, and they don't know. So it's a constant back and forth.
Right.
So that is heightened vulnerability. Living in virtual poverty and homelessness, right? With weeks before they can access services, and I'll pass it to Byron later. In a couple of moments, he'll delve on that.
Right.
But one piece that I want to pick up, because it really has to do with vulnerability and the potential for re-traumatization. Refugee claimants may become conventional refugees and protected persons if they pass the hearing. And at the hearing, they're asked to tell the stories. And we know that from a trauma recovery point of view, telling the story is not only not necessary or required, but it's actually counterproductive many times if it's not done in the appropriate way. So the thing is, they are expected to provide a cohesive, coherent, credible narrative of trauma. And trauma is above all fragmentary memory, implicit memory, dissociation, poor memory. So it is totally counterintuitive. And then they need to go through the process of talking to a stranger, a lawyer, and maybe it's the first time in their lives, and remember rupture of trust and safety. They need to share the story of what happened. Focus on the facts. Build, quote, quote, a case based on the story. Come up with a coherent narrative that can earn them the status. And then they need to be ready to function, to give testimony at the IRB hearing. And in the meantime, while they get ready for all this, they need to survive here in very precarious conditions where social determinants of health are not met. So they're going through a legal process in the midst of all the stuff that they're going through in their minds, in their bodies, in their hearts. So it's heightened vulnerability. So the more we can accompany them, not because they're fragile, but because they're vulnerable. They're extremely powerful. These are the guys that brought themselves here.
Yeah.
So they chose to come, and we need to tap on that. They chose to come. I want to be very clear here. Choice, quote, quote. But there's a part of them that helped them bring themselves here, even when the feeling is that there was no choice and no control. And that's inherent to the experience. I want to be very clear there. But there is that driving force, right? But having to access the story and tell the story, that is tricky.
Again and again.
That makes, from the point of view of mental health, that makes it much more sensitive. That requires that we be very, very cognizant of timing, interventions that we, as counselors, for example, apply. Predetermination period, meaning before the hearing, we are not going to, stir the pot. And if the client wants to really talk about it all, we need to do lots of containment. In trauma therapy, we talk about stage 1, 2, and 3. The first one being safety and stabilization and self-regulation, and helping people be here instead of being in the memory and function. And that's what we need to do. And not only counselors can do that. Settlement workers interrupting people, not getting too proud that people are sharing their stories, redirecting, staying in present moment. Physicians giving a roadmap, even when time is challenging, but saying, okay, we're gonna do this today. I know, let us, and then next, I'm gonna touch you here, touch. So many things. So I know, again, I could talk, and I know the rest of the people in the room have lots of things to say about this. Yeah.
Okay, so we have another question here. If a client gets referred to VAST, but they do not want to go to group counseling, would they be able to stay with one-on-one counseling services for a period of time?
Okay, so it's not mandatory to attend the Getting Through group for claimants. It's highly suggested, but the answer in a nutshell is yes. But one clarification, it's not group counseling. The Getting Through it is not group counseling. People need to be reassured. If you're thinking of referring a claimant to this group, reassure them that they're not gonna be required to push to share the story. The BOC, the basis of claim, stays where it stays. It's not like talking to a lawyer. They don't need to share that. This is a group to come together with many others refugee claimants that need tips, that need to learn what to do when they cannot sleep at night. We practice exercises for stress management, anxiety, coping with anxiety. I'm using very kind of, like language there, for self-regulation. There is information delivered, but we do not claim to replace the legal information that lawyers provide, right? We redirect, so we help them navigate the claim process with appropriate, timely information given in small doses. That's why it's a weekly group. We refer to the Ready Tour. We refer to Rainbow Refugee if this is a queer, self-identified as LGBTQ refugee claimant. Rainbow Refugee and I Belong is a resource. We refer to SOS if they already have been there, or to options, whoever the settlement players can be, depending on where the claimant lives. So reassure the clients that they won't be asked to share the stories. But still, we know that to some people, groups may be particularly challenging. So we don't impose, we suggest. Lawyers, refugee lawyers, these days, more and more, are sending, it's ever increasing, their clients to Getting Through it. They know that they're not going to be misinformed or flooded with conversations about the case and the trauma, but they're going to be stabilized and more able to function at the refugee hearing. That's our purpose. It's a predetermination phase intervention and a psychosocial trauma-informed group, not a counseling group.
Right. Okay. Thank you. Thanks for
No.
Okay.
That's a very fair question.
Great. Thank you, and thanks everybody for your questions. We are going to move on to our next speaker now. I would like to introduce Byron Figueroa, Health Promotion Case Manager from Settlement Orientation Services, or better known as SOS, who will be talking to us today. So thank you so much, Byron, for joining us, and please feel free to start.
Thank you. First of all, I want to inform you that you can contact us for any other questions related to health, mental health or physical health. As we always say, settlement workers, we are not only people who fill up papers or forms. We are somewhere mental health workers, because we have to ask questions, and during that process we have to contain a lot before we can refer them to the professionals, to BAST in this case. And we work really close to them with them. Let's go to the introduction of services that we have for refugee claimants. And let's start with the pre-claim, before they start their claim. Lately has been really busy in that matter, because soon, let's put it, as soon they cross the border, if they cross the border, we have a case, we have a person who have an accident crossing the border, was captured by the CBSA, and instead of processing that refugee or that claim, they send him to the hospital because have a fracture, an open fracture. That person end up owning to the hospital $28,000 that's I think that was White Rock Hospital. And the guy come, he's an engineer, a petroleum engineer back in his home country, but of course he come as a refugee with no money and with that big bill. We start talking at that moment. We start sending emails to the IFH office, and of course they cover those expenses in the end. Was a really hard moment for him, but we end up clarifying and resolving that situation. Some of these cases are related to the pre-claim. The criteria is not really in that clear in that matter, because sometimes the IFH, they cover the pre-claim medical services. Sometimes they don't have a explaining. They just say, no, we are not going to cover that. Let's put it in this way. We have a family that arrived as students, with visa students, and she got pregnant, and they delivered the baby, but they didn't have the eligibility session yet. They didn't have the IFH, the ID, and they end up with a big bill from the hospital. We contact, in this case, the IFH. IFH say that no, they're not going to cover that, because it's supposed, if they come as students, they must have some MSP, and they didn't have MSP. They end up paying the money to children and women hospital. Those are the pre-claim situation. During the claim, let's put it in this way, during the claim, clients are, after the eligibility interview, they are supplied, this picture that appears there are just a sample of some of the bills that our clients receive. Yeah, and surprise. During the claim, we have something called the IFH. The IFHP is the Interim Federal Health Program, and it's let's put it after the interview, the eligibility interview. CBSA confiscate all the documents, the personal IDs from their home countries, and they supply them with a Canadian ID called the Canadian ID, and in there is a paragraph that includes the medical coverage. If all of us, we have a care card, let's put it in this way, somewhere is similar to the care card services, with some exceptions. We are going to talk about the exceptions later. And the IFH covered the medical examination for immigration, and allow us to have, or allow refugee claimants to have services as any other person that pays for the medication. They can have dental services, and also they can visit an eye doctor. That is what supposed is going to happen, but it's really difficult to find health services provider that accept the IFH. And also with pharmacies, usually we don't refer them to big pharmacies because they don't supply them with the medication, charging the IFH. We prefer to send them to a small pharmacies where they take better care of their clients. Let's put it and let's do some commercials here. London Drugs, for example, if we go to London Drugs as any permanent resident or Canadian citizen, we can see that the workers there are really busy, and it's not their fault that they don't accept the IFH, because I'm sure there is a lot of or more paperwork for them. And if you have one of those cases, it's better if you refer them to small pharmacies. Dentists, they are registered on the directory of the Blue Cross, but it's difficult to find dentists for refugee claimants. What is covered with that? Usually are extractions or elimination of an infection. No more than that. No more than that. If somebody wants to go for cleaning, they say no, that is not covered. It's for emergencies only. After they get the work permit, because in the documents, in the IFH documents say if the immigration status of the refugee change, the person needs to look for another health services provider. Or in this case, when they get a work permit, the immigration status change. And we recommend clients, as soon they get their work permit, if they are not in social assistance, that means they are working. But we know that work permit doesn't come with work. They have to look for sometimes for that job. At that moment, let's put it that they can, if they apply to using social services to obtain an MSP, they are not going to receive a care card. They are going to receive a letter with the PH number, who is the personal health number, and they must be they have to be sure that that is active, because sometimes workers at the social services, they give the PHN, but they don't activate the PHN. And when they apply by their own, it's a $37 fee to obtain the MSP, and it's $37 not for family, it's for member of the family. They are not allowed to apply for the premium assistance, and they must pay in full the $37 per member of the family. Usually when we apply for the care card, takes 3 months for us to get the bill, and after we pay the bill in the bank, we have to we receive 1 week later the care card. And if they are working, I recommend them, after we send the application, recommend them to call in this case the MSP and request the PHN. Usually takes some time to connect with them, couple of hours. We don't do those phone calls in the office, and when they speak English, we advise them. If not, we recommend them to find a friend to do that phone call. Going back to the PHN, let's say that squeezing the best of their money, they must call the 1 week after we apply for the MSP, or 10 days, requesting the PHN, because they are going to ask them, why you want that? Are you sick? No, I'm working. An accident can occur, and that's why I need, or I have kids and I come from a tropical country, and you see the weather, my kids are going to get sick. They need some reason why we need them. And of course, as soon we apply, MSP start charging them, but they get the care card 3 months later. But we have to call them. That's one of our recommendations in that case. And going back a little to the IFH, we can see that what is covered by the IFH, and ambulances are covered, but let's see, as soon our clients receive the bill, we must contact the ambulances St. John's in order to explain to them and send them a copy of the IFH. Because if they, let's see, if 1 month passed, 30 days after, they are not going to accept the IFH, and they are going to keep sending them a request of the payment until they can send that to a collection office or agency. Some people is if when we come from a third world country, let's put it like that, we are not used to the services that we have in Canada. They say, oh, the ambulance just took me 2-3 blocks and they charged me this amount of money. And I explained to them, the driver of the ambulance is not just a driver of the ambulance, they're paramedics. And the ambulance actually is a mobile hospital. That's why they're charging you all that. But we have to deal with the bills of that situation. Let's see what other, as I say, they have access to eye doctor. We have to check with some eye doctors, especially those who are settlement workers. I suggest them to keep advocating, knocking doors with dental care services providers and eye doctors, because are kind of difficult to have those services. Let's see. Let's go to the other one. This is a sample of the what is the care card. And you have the information there. I don't need to go through that. What is the care card? And always it's really important to check with our clients if to talk to them. Are you working? Are you able to pay the care card? Because sometimes people say, I got the care card for free, and later they receive the bill, but they get infected with that situation that somebody told them, I have my care card, and the other one wants the care card. And I said, no, you have to pay for that. But my friend got that for free. I'm not going to apply, because sooner or later you are going to receive that bill. And they say, you have to apply. Okay, but don't blame me later and they come, you told me. Yes, I told you. Now what we can do, because if they apply for the MSP and they decide to cancel, they can cancel, but they have to pay at least 3 months, and they can reapply 1 year later. That is like a penalty in that case. That's why it's important to check with them if they are able to pay for that. Let's put it if with the IFH, the IFH is still in place if during the hearing is another word that is important to tell them. I'm going to the immigration court. No, it's not a court, it's a hearing. Another human is going to listen to you. It's not a court, because being a refugee is not, we are not criminals, we are refugees. And that's what we have to be clear to them, because sometimes people have been in their courts in unfair legal systems in their home countries, and that is scared of the word court. And let's say that if the decision is a negative decision, the IFH is still in place and still active. I mean, they are still having their the services. And if it's a negative decision, if it's a positive decision, the IFH is still active only for 45 days after they receive the confirmation letter that they become a protected person. And they must apply for the MSP if they're working. Of course, we suggest our clients, since they start working, that they need to apply for a care card, because let's put it like that person is working and is paying taxes and all the deductions. If an accident occurs, is not going to receive the benefits because IFH cover until such a place, but the person is working. They must apply for the MSP. Pharmacare is a tricky thing, especially it's not let's put it, IFH people are not entitled to pharmacare, with some exceptions. Some exceptions when they have a clinical condition. We work with refugees who are HIV positives, and that's when we can obtain, or we have to explain if somebody is a diabetic or if somebody have asthma. But we need to explain, and we need to fill up extra forms, and also we need a note from the doctor. Always we suggest our clients to check in walk-in clinics who is receiving the IFH. And before we get sick, I tell them it's important to knock doors, go if they and check with different walk-in clinics, go and check with different pharmacies, dental clinics, and eye doctor. If you're a settlement worker, I suggest you to recommend your clients if they found a person or a health services provider who is accepting the IFH, please let us know because we can dissipate that information among other clients. And that's it. I think that's all the information I have.
Great.
Yeah. If you have some questions, I'm here.
Yes, absolutely. Thank you so much, Byron. We do have some questions for you. For those of you who have questions, feel free to send them to events@amsa.org or just put them in the question box. So one person is saying, Byron, I am looking for information about how to find a physician who can complete the medical for a work permit. My client is currently in Canada. I don't know all the details of their status, but I think they were denied refugee status. Are there any designated physicians in Vancouver that can complete the medical report for a work permit?
Yes, that person was denied
That's what they're saying. They think, they're not sure, but yeah.
Okay. I think if they claim refugee status, the first medical immigration examination is free for clients because the IFH is going to pay for it, but that is going to expire in 1 year. If he's applying for work permit and his initial medical examination expire, that person needs to do another medical examination, and in this case, that person needs to pay for it, and it's between $280 to $300 to pay for it. Yeah, and then there are doctors in Vancouver. There are lots of doctors in Vancouver. He can, or that person can check. There is a doctor called Desmond Dwyer. Desmond Dwyer is on the corner of Willow and Broadway.
Is there a list anywhere that
there is a list.
Okay.
There is a list if they go to the immigration list, or sometimes for refugees they come with in the package. They come with the list.
Oh, I see. Okay.
And they don't know. If they don't know English or they don't know the package, I always ask them if they allow me to put my hands in their stuff, and I can. This is the list of the doctors.
It does sound like a. This is Mei Ling. You haven't met me yet.
Yes.
You will in just a moment. It does sound like there are some things that maybe need to be cleared up in this scenario, just to determine if they really, what their kind of options are before they go and pay $300 for the examination. It might make sense to assess the situation and see.
Oh, okay. That's all the time we have for questions. I know a lot of you do have some more questions. We'll hopefully try and have a dialogue after our final speaker, who I would now like to introduce formally, Dr. Mei Ling Wiedmeyer. She's going to review common challenges in access to healthcare for refugee claimants, and then she'll also begin our panel discussion on how to address these challenges and improve the access. And so you'll have a chance to ask some questions, and hopefully we'll have some dialogue around the table. So welcome, Mei Ling.
Thanks very much. I'm so grateful to be here. This is such an amazing panel with such intense knowledge, and I think this is going to be really rich. And I also, it occurs to me too that those of you in the audience also have a really rich experience, and so that was why I wanted to be light on my information dump and make sure we included time for us all to kind of ask our questions, because one of the things I've learned over time is that, you know, a question that you have is very likely a question that someone else has, and this is perhaps some way we could utilize some of our common expertise. All right, so I'm Mei Ling Wiedmeyer. I'm a family physician at the Umbrella Multicultural Health Cooperative. We are a collaborative health cooperative. We have a clinic in New Westminster where we provide health promotion and primary care for people who are identified as having barriers to primary care related to language or culture. We use a cross-cultural health broker model, which I don't have time to talk about today, but if you go to our website, you can learn a little bit about the work that we do there. So I recognize this was already done, but I always include this in my presentation just to say that I acknowledge that this work that we're doing takes place on the unceded traditional territories of the Musqueam, Squamish, and Coast Salish, or Tsleil-Waututh Coast Salish nations. And I do that because I think about this a lot. I think a lot about displacement and the impact of larger structures like colonialism on health. And I just think it's always important to remember our current contexts in terms of the work that we're doing now. I'm a physician, and so I just habitually include this in everything that I do, but I just thought I should be transparent and say that I have no financial or other conflicts of interest to disclose with regard to this presentation. All right, so I'm just going to spend a little bit of time briefly going through some common challenges. I do a lot of these presentations and have done over time. I was previously the medical coordinator for the Bridge Clinic, which some of you may be familiar with. And so I thought I would sort of preempt some of the discussion by just outlining some of the very common questions that I receive, and then talking a little bit about, common things that I usually suggest in order to address them, and then we'll have a discussion together with your specific questions. So the first thing is just IFHP. There is just nonstop confusion about this, although the confusion has gotten slightly better. It used to be like multiple slides of different levels of coverage for different people, and that has now changed so that the coverage is more similar across different categories of refugees, so that's helpful. But still, it's a confusing concept for people, especially if people are coming from different types of healthcare systems. One of the things, you already touched on this, but what is insurance and how does that work is often a new concept for people. And frankly, I'll be honest, because I'm an American, is even confusing for Canadians. So, but things I always kind of reiterate to patients or people that are in my care who are refugee claimants themselves who are going to be trying to access services, understand your rights. Sit down with your settlement worker, sit down with any of your friends, anybody, find out what your rights are with regard to the healthcare system. One of the things I always try to emphasize to people is do not pay upfront. This insurance system is designed to cover the same types of things that MSP covers. It's not a perfect match, but that's a general concept that's useful. And it's federally funded instead of provincially funded, and that is the only difference, practically speaking. And so it is inappropriate for healthcare providers and hospitals to be charging people upfront when they have IFHP. Sometimes they do it anyway, and then we fight with them at the back end in their finance department. But really, that can be preempted by knowing your rights, not paying upfront, and making sure that you have your document with you when you try to receive services. Because as much as we are a fairly developed nation, our primary care and other healthcare systems lack a lot of coordination. So, if I put your name into a computer, I won't know very much about you. It's not like the computer says, oh, they're a refugee claimant and they came this time. Like, none of that information comes up. So you have to bring that information with you up front. Okay. So for provider level IFP challenges, woof, sorry, it's late middle afternoon. We've already been talking about it. The most common thing I hear is, I don't take that insurance. Yeah. This is a systemic issue. It does help for settlement workers and other frontline advocates to understand how to talk to providers about IFH. So to do some provider outreach as you're going along in your interactions. The things that I tend to say that are effective are, it's easy and pays faster than MSP. This may not make sense to anybody else here, but if you say that to a physician's office, they will listen. Because the process by which physicians can submit billing for payment is basically identical. It's actually very simple. It's very easy to sign up. It just requires going to one website and putting in your information. I suggest teaching MOAs to do that stuff because it's much easier for them to do it than the doctor to do it. And in the instance you're working with a hospital or a health authority service, talk to finance. Always talk to finance. Ask to talk to finance if anyone at the front line is giving your client any trouble about the IFHP. It takes a lot of advocacy, and I just will note that it is a system level issue, and that's something that we're working on to address at a systemic level, but and we know it's a problem. I say we, I'm just talking about like groups of providers who understand this and have been working with this for a long time, but that there is advocacy going on at a provincial level about trying to make some of these aspects of healthcare access have fewer barriers, just so you know. The IFHP program, as was already well described, so I'm not going to belabor that, but the document that you were describing looks sort of like the one pictured here. Super easy to register to be a provider, so bring that website with you if you happen to be accompanying patients places, or in your case, your clients. I don't know actually the words I use. So, and then just there's levels of coverage, and this becomes confusing. Not always for refugee claimants because it kind of the coverage stays the same until they have their hearing, and then it changes. But IFHP has 2 levels: basic coverage, which is designed to be essentially equivalent to whatever that province covers on their insurance plan. So in our case, that's MSP. So the medical services covered under IFH should more or less approximate MSP. Same things, which in our cases is like midwifery, doctor services, imaging, and blood work. Supplemental coverage and prescription drug coverage is covered by IFH similarly to what people who are low income on income assistance would get in the province. Again, it's not a perfect match, but it's designed to be roughly similar. So for medication, the medications that are covered can be identified through going to the BC formulary. It will tell you which pharmacare medications are covered, and you can pretty much assume that IFH covers those same ones. Again, it's not perfect, and sometimes you have to write notes, but that should more or less work. And then supplemental coverage is for sort of things outside of like what would be covered by MSP or medications. So vision, dental, and devices. So wheelchairs, braces, other things like that can be covered there. You know, surgical supplies that people are using at home and things like that. Those may require some prior approval, so there is some provider education around people like sort of home health and other places in the community that might be billing for to get reimbursed by the government to provide supplies, but it can be done. So MSP delays. So this is where the confusion around PHNs and there's just like lots of letters flying around. But one of the things that can be very confusing for people is that although their IFH will cover MSP covered services until their hearing, and then it changes depending on the outcome of their hearing. If you have a work permit, you can apply for MSP. But regardless, if you're applying for MSP either through the work permit or after you've been accepted at your refugee hearing, there's a 3-month delay. So that is just a policy of the province that after, when new people arrive and they have permanent residency, like even if you arrive from another province, there's a 3-month delay before you can get MSP. And so obviously human health does not just go on pause for 3 months. So people definitely have health issues during this window period, and that's extremely problematic. So the only thing to do here is to really just be aware that this is an issue. I try to warn people in advance, especially if their hearing is coming up. You know, I try to load up their medications and other things like that, because I know that if they get accepted, IFH drops out after 45 days, but MSP doesn't pick up for, best case scenario, 90 days. Yeah. And and there's a dropout. And obviously, if you or your child or anybody gets sick, you need to use the hospital. It's very confusing because they've been accepted to Canada, and then one of their insurances that was working dropped out, and the other one hasn't started yet. And it's just this kind of strange dilemma, but obviously people get stuck in it inappropriately. So again, that's something we're working at the system level to address, but you can warn people in advance. I tell them just submit your paperwork as soon as humanly possible. You need to put those applications in as soon as you're eligible. You can apply to IFH to extend it to cover that gap in some situations. So if people have like ongoing medical conditions, diabetes, and other things like that, you can apply to extend the IFH to cover that dropout period. Okay, language barriers. Yeah, so one of the things that I always find hilarious when I'm making referrals is that all of this like specialists will say on their website, patients must bring their own interpreters. So yes and no. I think ethically that's inappropriate, but that's my personal opinion. I guess I should make that disclosure. But you know, in the United States, there's precedent for interpreter provision that's incumbent upon the provider, and I'm hoping that we'll be able to move to that here in Canada. One of the things that's helpful to know is that there is a telephone interpreter called PLS. All community level physicians throughout British Columbia should have access to this phone interpreter for free. I tend to bring a little card that has the information on it and give it to people so that they know that they can and should use the telephone interpreter. But people rarely use it because they feel it will take additional time. But anyway, I try to encourage people to use it because they'll ultimately be able to make more appropriate clinical decisions if they have interpretation. So face-to-face interpreters are also available in a number of different settings. You know, I tend to prefer professional interpreters, but I do understand that's not always available, and sometimes you have to make a judgment call. So there are interpreters through NGOs such as Mosaic and other places. It depends a little where you are in the province, and I recognize that this will look different in different settings. Friends or family, I generally discourage unless absolutely necessary, and you can just suggest to any provider, like, or if a patient is trying to figure out, like, is my only option to go with like a family member, like, are you comfortable, like, talking about things that, you know, you would want your brother to know if they were in the room with you. Sometimes providers will really push just to say, oh, it's fine, the wife can translate or whoever. And I just sort of suggest to them, just ask yourself, if you were in another country and you needed medical care, is this something that you would want a family member in the room with you for? As a general rule, do not use children. Just don't. I've seen that happen, but don't do it. And if you see that happen to someone that's in your care or that you're supporting, please step in. Do not, in any setting, let a healthcare provider try to get a child to translate for their family member. Okay. Finally, system navigation. How do I find a doctor? I mean, how do I find a family doctor is a secondary question that is truly difficult for everyone. And as a family doctor, I apologize for that. There's huge systemic issues that, again, we're working on. But I just say, like, all hands on deck, do whatever you can that works, basically. So ask everyone you know. If your friend finds a family doctor, ask if they'll take you to. Just keep asking and keep trying. It is difficult. I do say, you know, if your clients find someone who is taking patients, like, learn that person, go talk to them, like, be friendly with them, see if they can take more, because it's just hard in this environment. There are some immigrant-specific clinics. Most of them are referral-based. Some of them are through Fraser Health in Surrey and Burnaby. You know, our clinic also, unfortunately, we had to recently cap our wait list because the need is so great and our capacity is not great yet. But there are immigrant-specific clinics that I find are useful, especially for people who are especially vulnerable or especially complex medically. And so they often will have a wait list, but will prioritize refugee claimants, especially if they're medically or psychologically complex. Urgent care clinics, there's a couple of new urgent primary care centers that have opened, one in Surrey and one in Vancouver, and they should be able to take IFH. Sometimes they do and sometimes they don't. They definitely obviously will take MSP, and they all should be able to use the telephone interpreter. And then community organizations and navigators are obviously so essential to this piece. Figuring out, how to find places, what is a specialist, like why do I have to get a referral, where do I find this, that, and the other, are all super difficult questions when you just arrive in a new place and you're trying to learn a new system. And so I know some community organizations provide medical navigators, specifically in Surrey, that can help with some of this just system navigation concern. Finally, we talked a lot about this, so I won't spend too long, but just, obviously people come along a continuum of life experience, both of cultural experience and maybe traumatic experience. There may be things that they discuss with you. They say, I can't talk to my doctor about this. And so I've just included a couple of things. I mean, obviously VAST is an enormous resource. I find debriefing, it might be helpful to talk about why is it you can't, like, what can you talk about with this doctor? Like, how might we kind of think through this situation so you can still get some help without disclosing what you don't want to disclose for whatever reason about that clinician. I advocate with clinicians to remind them about people's stories, not telling them the story, but just reminding them of that continuum. Normalized responses, again, is the same thing. This is a normal response to an abnormal situation, and just reminding people that it's understandable that you would feel the way that you feel in this setting right now. And then obviously trauma-informed care and trauma-informed approaches are critical. Culturally Connected is a fun thing I use for my learners. It's just like a little website that takes a cultural humility approach, which I think is really useful, a little bit better than cultural competency, which is like, let me learn 5 things about Syria. I think we all agree that the breadth and diversity of human experience is a little bit more than that. So it's an approach that just has little vignettes to sort of learn how to be use a cultural humility approach, and it can be, you can take that to providers as well as an advocacy tool. It's very simple and helpful. Okay. And now I would be delighted to hear from you. I am sure that you have some questions. Earlier we were sort of joking, like we had some questions prepared in case you don't have questions, but I've never met a group like this that didn't have questions. So what do you say? Are there some questions there?
Yeah, great. Thank you so much, Mei-Ling. So it looks like we have quite a few questions. So we'll ask it, and then feel free to answer, or if you want to start the dialogue.
There's one thing I forgot.
Okay,
I just have a note to myself on my paper around the medical legal documentation. That is something that is unique to refugee claimants. Okay. It is a very, very important aspect because it can make a huge difference in the outcome of their refugee claim, to have very appropriately documented, like a medical legal letter to include in their application. It is a skill to write those. And so that to that end, for any of you that work with providers, I will be co-facilitating a workshop at the North American Refugee Health Conference that's in Toronto in June, along with a lawyer and some psychiatrists and other primary care clinicians around how to write these letters effectively for your clients. So if you know someone that, usually it's more or less for clinicians, but if you know someone that might benefit from that, for sure, please tell them about that.
Okay, and will you be able to share that information with us, and Bahar
sure,
can post it? Okay, that'd be great.
Just email me or remind.
Great, thanks so much.
Yeah.
Okay, so here's the first one. Do you know of support for claimants in detention, in particular mental health support? We can open that up, and Mariana, if you want to start, and then feel free, Byron and Mei-Ling, to
I can speak to what we've been noticing is happening and what has been promised that is going to be happening. So what is happening is not much, right? Supports, mental health supports in detention, not really a reality, non-existent. How many ways to put it. Now, with the CBSA introducing the Alternatives to Detention program that they launched some time ago, I'm back with dates, please remind me, people in the room, but it's not that long ago. In the summer, we nonprofits, service providers met with the CBSA in summer engagement sessions, and they been talking more about the Alternatives to Detention program. And last week they were at the MAP, the multi-agency partnership that gets together many of us, right, service providers and government. They gave us an update. Once again, they said, well, we will have, when the Immigration Holding Center, that's how they call it, in Surrey finally opens, and that will be in June, we're going to have presence of mental health supports there.
Oh, great. Okay.
Yeah, but at the same time, a couple of us, Vast included, and I myself personally, we said, okay, what does that mental health support look like? Who are going to be these folks? And they mentioned a psychiatrist and a psychologist, and not last week at the MAP, but before in the summer sessions, they mentioned a couple of times per month. So it didn't seem to be something ongoing. And also, it is a very different role, the one that a psychiatrist has or a psychologist, as opposed to a registered counselor. Each one supplements the other, and they're not mutually exclusive. And also, I believe that we need to hold the CBSA accountable for the quality of the services in detention, because they need to, we're talking about not any type of trauma, we're talking about refugee trauma. Forced migration, state violence, a trauma-informed lens is indispensable. Providers, whether it's psychologists, psychiatrists, or even counselors that are designated to be there, need to be specialized in refugee trauma. And with this cross-cultural humility and lens,
Right.
and this trauma-informed practice. So we offer from the beginning, when they first started talking about Alternatives to Detention program, to help train the service providers in detention in these specific pieces of the work. They may know the clinical stuff, they may know about PTSD, but these layers of the work. And then overall training to all the different layers of workers at the detention center, although they call it holding center, for everyone to be trauma informed. And then they also promise, and then let's remind ourselves so we hold them accountable, they promise NGO presence there to bear witness as to how this is going to be in place. So to the question of mental health supports for the folks in detention, there seems to be changes coming up, but we want to make sure that the changes are good ones, and the quality, the framework of the work is suitable for the work with refugees and refugee claimants. I keep mentioning refugee claimants because it's our focus today, but refugees are not.
There's a couple of questions that are coming up here, so I'll just read them out loud. The first is about a refugee claimant, pregnant woman who could not find a maternity specialist doctor, and what should she do? So there's a couple of different options. There is the depends on where you're located, but there is the New Beginnings Clinic that's in the BC Women's Hospital. They will accept refugee claimants. They can bill IFH. They provide services for pregnancy and a little bit after delivery, but they don't really do kind of wraparound support for the baby as well. It's purely just prenatal care and delivery. They should be able to provide translation there. And there is an application process to get into the clinic, and it is a bit onerous, but they should be able to do it if they're in Vancouver. Other places that do accept IFH, it depends a little bit on how complex the pregnancy is. If you're in a real pinch, email me directly. There is the Burnaby Maternity Clinic, which can take IFH, which does use the phone interpreters and delivers at Burnaby Hospital. There are individual providers in Surrey. It's a little bit of a case by case there. Yeah, I hope that helps.
Thank you.
Yeah.
So we have another question here is how do claimants apply to receive the supplements to do with healthcare?
Anybody that has IFH has the supplemental benefits.
Okay.
It's just that in order to get the things from the benefit grid that are listed, it requires a system of prior approval. So sometimes like a physician will have to write a prescription for like a wrist brace or whatever it is. And then they have to take it to either the home health place or the pharmacy that's going to do it. And the pharmacy has to submit a special claim form to IFH. It has to be pre-approved, and then they'll receive their brace after that approval. So sometimes it can take a couple of weeks in terms of the process, but anybody who is on IFH has access to those benefits.
Okay, great. Thank you. That's helpful. Okay, so, somebody gave us some information that we'd like to share.
Great.
So somebody said, have you heard of Roots Community Health
Sure.
Center?
Yeah.
Medical clinic with physicians and other healthcare professionals working in a team-based care model that sees these refugee claimants for all their healthcare services located in Surrey, BC, and lots of nods, so you
Yes.
all know of that.
Yes,
And,
they are just getting off the ground, so I know their capacity is just that they are at a position where they're growing.
Okay.
So I think it's a great initiative. It's in partnership with the Surrey North Delta Divisions of Family Practice. And so I do think that it would be a great option for those people living in that area, but I'm fairly sure that they do have some criteria around where people are located in terms of a catchment.
Oh, okay. Okay, that's good to know. Thank you.
Yeah.
So we have a question specifically for Byron. Could you please mention one clinic where there is Spanish-speaking staff that you may know of?
General doctor?
I think it's just general medical information, yeah. They haven't specified. But.
Okay, Dr. Eric Kadeski is 777 West Broadway.
777 West Broadway. Great, thank you. And
Yeah.
Mei-Ling, yeah?
I mean, it depends on if you're looking for urgent care, what you're looking for, but we have several Spanish-speaking staff at my clinic. So if you're just looking for routine primary care, but you don't have any urgent health issues, you're welcome to join our wait list. And then finally, we're in like New West, so anyway, if you're out there. And then also, if you just go onto the College of Physicians and Surgeons website, the cpsb.ca, cpsbc.ca, and then there's a filter for language. So you can just filter for Spanish-speaking providers, depending on what you're looking for.
Great, thank you. So it was, sorry, could you say that again?
cpsbc.ca.
cpsbc.ca.
College of Physicians and Surgeons of BC.
Okay, excellent. Thank you. People from other parts of British Columbia are
Love to hear
asking,
that.
do you know of any healthcare providers for new Canadians in the Okanagan?
Yep. So there is a refugee health nurse. That's in the Interior Health Authority, yes?
Yes.
Okay. So they do have a nurse named Daniela Widmer there who is, her job is to connect refugees and their sponsors and other support staff with healthcare in the interior. So if you connect with me directly, I can connect you with her.
Okay, great. Thank you. Here's a bit of a long one. So let's see if we can. Okay, if patients have IFHP, can they still access BC 811?
Yeah.
And I'm just going to say this for people who may not know. BC 811 is a phone service that has 24/7 free phone access to a registered nurse. Different, only for medical, you can get medical advice and can help prevent a trip to the clinic or ER. And they provide translation services in over 130 languages. Yeah. So the question is, if patients have IFHP, can they still access BC 811?
Oh, absolutely.
Yes.
Yeah,
Okay,
anybody
great.
can. In fact, I use that as a little unofficial translator. Like, so if you're in a real pinch, you can actually call 811 and essentially be like, I need Anyway, you shouldn't, it's not official. I'm not allowed to officially. You didn't hear that from me.
Okay, so the answer is yes. Okay,
Yes.
great, thank you. Are there any government-funded medical clinics available for refugee claimants that only have IFH, or do physicians just bill IFH?
There aren't really any government-funded clinics for,
No, eh?
no.
Okay.
I mean, clinics here, if they do have some kind of alternative funding, would be funded through health authorities.
Right.
So I do know that the Global Family Clinic, for example, in the Fraser Health Authority, can take anybody with IFHP or MSP or undocumented. But generally speaking, doctors just, or any providers, just bill the IFHP program. So yeah.
Okay.
So, and I want to add something, because this is a regular conversation that they're getting through it group that we have at us for refugee claimants every week. There's always questions about IFH and the MSP being inactive and the transition. When can I apply? When I should apply? And we keep redirecting to people like Byron, or we are reassured when we know that those claimants are seen at places like Umbrella Co-op, because we know that the providers will be aboard with them with that advocacy piece. So as much as we all know about the places, the providers that are IFH friendly, and of course, in order to save time and energy, we say to clients, go there, but we also need to, and we actually do say to clients, know your rights, as Melanie was saying.
Right.
This is true. These are IFH friendly people. They are aware of it. The other ones need to be educated. And we service providers, physicians, counselors, settlement workers, people out there listening to us today, we all do it. And we need to empower the claimants to do it. So this paper, I know it's a big one, it's not a card, but this is your health coverage. You have one. You're entitled to services, and it's called this, and this is what it means. And that means that you can go, and if people say, no, we don't take it, they need to be educated. So maybe let us make a copy.
Yeah.
And a group, we always have copy of the IFH coverage. So people can take one. And then they can go and say, and maybe the mantra that you mentioned, it pays more and it's faster.
It doesn't pay more, but it pays faster. It's
It pays
the same.
faster. So that was my, yeah, but it pays in terms of time. It's not effective.
It's an incentive.
So
Definitely.
maybe, and kind of said, I've been told this is the government coverage that I have. And maybe it's not the one that you use the most. So really empowering people to do that themselves and know that we are backing them up, instead of encouraging them to keep going to the same old places that, of course, are inclusive and I understand, and they're the pioneers to accept IFH. But otherwise, we're taking for granted that the sector is not being educated, and we are colluding with that. So we need to enter an activism advocacy thing and say, and that's healing. And that at last, and many of us, not only at last, believe that healing is resistance, and resistance is healing.
The
So
other framing
we need to
that
do
is
that.
helpful, if you
People love it.
Yeah.
I group people feel like,
Yeah.
that did me good in itself. When I hear, I go there and I tell that woman that gave me trouble.
Yeah.
He didn't use those words.
But the other framing that can be helpful is that people can say, it's federal insurance similar to that which our service members receive, or First Nations. It's just very similar to those, veterans or government employees. So
that's
similar.
A good one.
Yeah.
That can make them click, right?
Okay, so we have another question. We have one participant who's saying, we are seeing an increase in the number of refugee claimants coming to the North Shore from Iran. There is a demand for crisis counseling and support groups for clients who have experienced trauma. Also, there is a need for support services for youth refugee claimants. Any suggestions on North Shore specific resources and programs that work with refugee claimants for both primary and mental health care?
I know a psychologist.
Yeah.
Qasim Al-Mashat, who has some specialization in youth and mental health and is familiar with IFH. In order for him to access those benefits, he would need a doctor's referral.
Okay.
So,
Accessing the IFH covered mental health supports is quite a thing. We
Yeah.
are nodding a lot
Yeah.
in this room right now. We've been fighting to make that happen. We're signing out a lot. But in terms of the North Shore,
Yeah.
there's a ever increasing number of Persian, right, refugee claimants residing there. Many of them come to group, or most of them. But in terms of the individual, the family services of the North Shore, I know the new clinical supervisor there is someone that was for years connected to Mosaic. So he's very cognizant, John Dubé, the lovely John Dubé.
Oh, John Dubé is there now.
Yeah.
Oh, nice.
So
Okay.
I would definitely try, because I trust that organization, and with him as clinical supervisor, will make sure to trick things so as to make refugee claimants as eligible to everything as possible.
Right.
I cannot speak to that. But then, the whole thing, right?
Oh,
of
it's so
finding-
difficult. Yeah, it's very challenging. I don't know the North Shore super well, but I know that they are in the VCH catchment. So you could theoretically go to the Access and it's AAC. I can't
The
remember.
Access and Assessment
That's what it
Center
is.
at
Yeah.
VGH.
It's at VGH.
We go there.
They have a Farsi speaking psychiatrist, and they have a Farsi speaking clinical counselor there. So that would be another option. It's self-refer. You can just go in there, and they do like to know if you're a refugee claimant and if you need an interpreter in advance.
Okay.
But they should be able to help. Yeah.
So
And
Access and Assessment
Center at VGH. But
Okay.
and they can always come to us. We see lots of people from the North
Right.
Shore, and if they are to come to us, I would suggest that they come to the Vancouver location. This one, the one at the ISS BC Welcome Center,
Right.
1 block away to Commercial Drive
Scheduled.
Station.
Yeah.
So
Yeah.
C-Bus, of course, it's not that bad.
Yeah.
It's 2 zones at certain times of the day, and most times of days when appointments happen.
Yes.
But
Okay.
but they're more than welcome to do so.
Great. And also in French, there are the Francophone services of PHSA, and also the directory of Réseau Santé. I remember AMSA used to share an office, sort of the building with
Absolutely.
Réseau
Yeah,
Santé.
absolutely.
But they're
Yeah,
very
It's a great
good.
resource.
Yeah,
Yeah,
very
for
good
navigation,
resource.
especially. Yeah.
Right.
For Francophone.
Okay. Great, thank you. We would love to continue this dialogue, but we are running out of time. But thank you to all three of you, Mariana and Byron and Mei-Ling. Thank you so much for being
thank you so
here
much.
and for your time. We really appreciate it. And thank you to all the participants who logged on today. We learned a lot from all of you, and you can tell from all the questions that people have that this is a very
That's
hot
great.
topic. Just to let you know that we will be emailing everybody an online evaluation form. Please take the time to complete it, as we really do rely on the feedback that you provide in the evaluations to plan future events and trainings. And again, the BC Refugee Hub would like to gratefully acknowledge the financial support of the province of British Columbia through the Ministry of Jobs, Trade and Technology. And we will be posting the presentations and all the resources on the BC Refugee Hub website at bcrefugeehub.ca. Bahar will be notifying everyone via the Hub newsletter. So if you would like to receive this notification, please join the newsletter mailing list. Great. Thank you so much, everybody, and have a good rest of your afternoon. Thank you.
Thank you.